historically, when you look at knee replacement, there's always been about 20% of patients that don't really like their knee replacement or unsatisfied. And the majority of the reasons for that are mainly they can't do the high function activities like stair climbing, workout activities, and the knee doesn't feel normal to them. The other issue has been in knee replacement is this ultimate survivorship. And so, historically, we haven't been as willing to do joint replacement in younger patients because we don't have long-term survivorship past the 15, 20-year mark. And so you take a 40-year-old who has knee arthritis, and you're not really excited about doing a knee replacement because you're setting them up to have multiple revisions over their lifetime. And so the two things that are changing now are, number one is what we call kinematic alignment or patient-specific alignment, and number two is cementless knee arthroplasty or cementless knee replacement. And starting with the kinematic alignment, traditionally with knee replacement, we basically make cuts based upon just the implants themselves, and then we balance all the ligaments, so basically release the ligaments to create a rectangular gap is what we call it in both with the knee straighten extension and the knee inflection. The problem with that is we don't have a normal or a regular rectangle in extension and a rectangle inflection. The normal knee has more of a trapezoid inflection, and so it creates this thing called flexion instability. And that's when people really don't like the way their knee feels. They feel like it's unstable when they're trying to do these squatting and stair climbing activities. And so with patient-specific alignment or kinematic alignment, what we're able to do is cut the knee based on the patient's anatomy. So we're more resurfacing the knee rather than replacing the knee. So we have to do no ligament releases, and it gives the patient a much tighter feeling, a much more normal feeling knee. More so like they have their normal ligaments rather than they've been released or cut out. Now the next step in this is robotics and navigation and how that allows us to really fine-tune this. So currently we do this using more manual type instruments, and as more robotics progress and as we become more adept at using navigation techniques to balance and to measure the normal bony architecture and alignment, this is really going to fine-tune this to where we can really give patients essentially the anatomy that they had prior to developing arthritis. And then on the other side of this is the cementless knee technology. So the way traditional cemented knee arthroplasty works is basically we use a cement grout, same thing the dentists use when they crown or cap teeth. And the ultimate failure point in a knee replacement long term is it loosens at that cement mantle. And so the whole driving force has been, how do we get rid of the cement mantle? In hip replacement now for about 19 years, we've had cementless technology and better plastic, and those have been really the driving forces to long-term hip survivorship. And so now with 3D printing and better materials, we've basically taken that to the knee. So far with midterm data, cementless knee replacement has shown wonderful survivorship. We're actually asking your bone to grow onto the components rather than relying on the cement. And so if you take the two things of patient-specific alignment and then you add cementless knee technology, what we're hoping is that the patients, especially younger patients, are getting a more normal feeling knee, a more functional knee, a knee that will hopefully last them for the rest of their life. So one of the driving forces now in joint arthroplasty is we're doing more and more cases and we're doing more and more joint replacements in the surgery center. And this allows for a lot of things. Number one, the patient experience is better. Really, as the surgeon, we control more of the process. And so we get to really make sure that the patient's taken care of, and we get to make sure that they're mobilizing early and all those types of things. The patients always seem to enjoy the outpatient experience more. We have data that shows that it's as safe as being done in the hospital, and that there's trends towards a faster recovery afterwards. The other thing that's driving outpatient total joint surgery is, frankly, economics. So as we move into a healthcare world that's becoming more and more expensive, we're trying to find ways to really decrease the burden or economic burden on the healthcare system. And one of the things that we can certainly do in the outpatient center is do a total joint replacement for far less of a cost compared to a hospital inpatient system. And so those two things are driving patients to the surgery center. Traditionally 10, 15 years ago, joint replacement patients spent 3 to 5 days in the hospital. It was a pretty miserable recovery, and it really took 3 to 4 months to get over their joint replacement, if not up to 6 to 12 months, up to a year. And so we've really tried to come up with different techniques that allow patients to not only rapidly recover, but really feel better long-term faster. So some things that we do around the time of surgery We use peri-cocktail injection, so basically around the knee we inject quite a bit of numbing medicine. Our blood loss medications have really kind of revolutionized our ability to do outpatient joint surgery. We do it under spinal anesthetic, so folks really don't have that same nausea that they had before with general anesthesia. They don't feel groggy after surgery. They want to get up and walk. And then we have the surgical technique standpoint. So one of the things with traditional knee replacement and mechanical alignment is we're releasing all of the ligaments in order to balance the knee. And the problem with that is the part that you have to recover from is the ligament releasing, right? So if you think about an athlete that has an MCL tear, we're essentially doing that to the MCL, and then we're asking it to heal back down with traditional knee replacement. And just like an athlete has a 6 to 12 week recovery, that knee replacement patient also does. So with kinematic or patient-specific alignment, what we're able to do is leave the ligaments alone and just adjust our bone cuts. And so by doing that, you know, there's very good data coming out now, and just as I've seen it in my practice, patients recover much faster, their knee feels more normal earlier, and it really allows them to basically walk out of the surgery center, go home, and then go to therapy the next day. The surgery itself is easier on the patient. And you know, I joke with some of the patients, you know, as my practice has evolved into this patient-specific alignment, my knee replacement patients look more like my knee scope patients did back in the day rather than a traditional knee replacement patient.